We'll continue with the pathophysiology of pneumonia. So, we were discussing about the classification and also the agents which is causing pneumonia. Also, we have seen specific agents are there and non-specific agents are also which leads to pneumonia. So, in the pathophysiology, the organism reach the lung to cause pneumonia by one of the four routes. So, any routes will be used by the organism to reach the alveoli and the terminal portion of the respiratory tract. It can be inhalation of the microbes, aspiration of organisms, hematogenous routes. From the distance part, blood carries the organism to the lung area and direct spread also can be there. So, then pneumonia may manifest as a localized or lobar pneumonia or as a bronchopneumonia by the following four distinct phases. So, there are four distinct phases in the pneumonia. They are stage of congestion, red hepatization, grey hepatization, and resolution. So, these are the four stages through which the pneumonia happens to an individual or pathophysiological changes what happens in the pneumonia. So, stage of congestion, that means there will be presence of bacteria or any organism in the alveoli causes vasodilatation and outpouring of edema fluid into the alveoli. So what happens is it is a stage of congestion. Bacteria has entered. During that time there will be vasodilatation. So vasodilatation is trying to give more amount of defensive cells to reach out the bacteria. So they will be outpouring of edema fluid into the alveoli. So vasodilatation, the surrounding alveolar blood vessels will be dilated and this will be trying to pour more amount of fluid into the alveoli as a part of inflammation. This pouring is trying to trying to cover the bacteria. So it is a part of defense mechanism. So red hepatization, the alveoli contain leukocytosis and RBC. The lobe is dry, solid and granular. Leukocytes ingest bacteria. So red hepatization, so more amount of oozing of the components from blood will happen to the alveoli. So leukocytes, RBC and macrophages will be entering into the alveoli. This is trying to kill the bacteria. So it will be like a solid matter, and red hepatization, that means it is looking like a red part of liver. Normally air cells or the alveoli is hollow spaces. It is filled with red colored solid matter. This is to defense against the bacteria. So more amount of blood and other products will be coming to the alveoli and it will be look like a solid matter like liver. Next is the grey hepatization. Still it is also a solid matter. The affected lung is solid. The surface is dry and granular. It is greyish white in color. Opsonic antibodies are detectable. So IgA and other antibodies will be present, and now the red cells will be destructing easily and it will be giving a grey color for the alveolar space. Next is within 8 to 9 days it will happen resolution, that is inflammation process subsides. So ഇതിന് ചുറ്റും വന്ന ബാക്ടീരിയനെ എല്ലാം കൂടിയും ഈ സെൽസ് എല്ലാം ല്യൂക്കോസൈഡ്സ് എല്ലാം കൂടി കില്ല് ചെയ്ത് inflammation subsides. Macrophages reach the site and remove cellular and bacterial debris. Fibrin deposition is seen on the pleural surface. So that is a resolution. So body itself make a defense mechanism against the pneumonia, against the bacteria or viral agent which is entered. So this happens through these four stages. That is stage of congestion, vasodilatation സംഭവിക്കുന്നു. അതുകൊണ്ട് more pouring of blood and other products to the leaking of blood and other products from blood to the alveolar area. It looks like say red liver because it is a solid matter will be present in the air cells. So that is leads to red hepatization. Grey hepatization, red color മാറി കൂടുതൽ amount leukocytes presence വരുന്ന സമയത്ത് it gives a grey hepatization, grey color, and it will be resolution will be happening. So one more important point which I wanted to add in this is, normally any person, when the person is getting pneumonia, these 4 stages will be happening and normally the resolution will be happening. But when we are starting the antibiotics, these all 4 stages may not be coming, because maybe in a stage of congestion we will start antibiotics and the person will be going for resolution immediately without the red hepatization or grey hepatization stages. So this is if we are not treating with the antibiotics, the person will be going through these 4 stages of pathophysiological changes of pneumonia. So airway, what happens is, normal alveoli air space is very empty, it's only filling with air. Now with the pneumonia, inflammation in the alveolar walls leads to the leakage of fluid, macrophages, leukocytes, some amount of RBC into the alveolar space, and it is filled with the bacteria and the blood cells, leads to initially red hepatization, later it becomes grey hepatized, and later it becomes the resoluted. So this is again the picture showing the gas exchange and failure of gas exchange when it is filled with the fluid. So next we can see the clinical features. Clinical features in infants. Onset, it is preceded by mild upper respiratory infection, purulent conjunctivitis, otitis media. Next is abrupt onset of fever will be the pneumonia. There will be fever, peak temperature will be there. Then the convulsions, diarrhea, vomiting. Cough is usually absent. Restlessness, respiratory rate in newborn is more than 60 per minute. In infants it is more than 50 per minute. We have already seen the rate of small children in the previous slide. Flaring of nares, then rapid shallow breathing, abdominal distension, slight cyanosis, tachycardia will be there, and rales are also present. And in older children there will be high fever, hacking cough, sputum may be rusty in pneumococcal pneumonia, and apple jelly in Haemophilus influenza. Then increased respiratory rate in heart rate. Chest pain on the affected side is due to the involvement of pleura. So some of the important types of pneumonia and how the person will be presenting in these all pneumonia, that we can see some of the important pneumonia. So first one is pneumococcal pneumonia. Respiratory infections due to Streptococcus pneumoniae are transmitted by droplets and are more common in the winter months. So it is droplet nuclei will be spreading this particular pneumonia. And pathology, here the bacteria multiply in the alveoli and inflammatory exudates are formed. So any of the routes, it will be entering in the alveoli and it will be initiating the inflammatory mechanism, and the fluid will be formed and exudates will be filling in the alveolar space. Scattered areas of consolidation. Consolidation is nothing but air spaces are filled with the solid matter. So solid matter is made up of this exudates, debris, mucus, and parts of blood products. There is no tissue necrosis. It can cause broncho or lobar pneumonia. Right upper lobe involvement causes meningitis. Then lower lobe involvement causes hiccups due to involvement of diaphragm. So these are the pathological changes which is happening in the pneumonia. In streptococcal pneumonia, the causative organism is group A beta hemolytic streptococci. Upper respiratory tract infection is more common, and it is more common in certain viral infections like measles, chickenpox, influenza, and rubella. So after these infections, the person may be presenting some amount of streptococcal pneumonia as a complication of these viral infections. Then pathology, it causes tracheitis, bronchitis, or interstitial pneumonia. Necrotic ulcers are seen in trachea and bronchi. So we have seen in pneumococcal pneumonia there is no necrosis. Here streptococcal pneumonia there is necrosis of the tissues common, and bronchioles are plagued with mucopus and necrotic debris. Extensive involvement of lymphatic channels towards the lymph nodes and towards pleural space occurs. Hilar adenopathy is present, and 1/3 of patients are associated with pleural effusion. So, slightly complications are more in streptococcal pneumonia than the previous one. So, this is the identification of streptococcus pneumonia in slides, in the secretions. Next is a staphylococcus pneumonia. It is also occurs in infancy and childhood. It is caused by Staphylococcus aureus, which is a gram-positive coccus, and is common seen in right side. That is, in 65% of the cases we can see it in the right lungs. And pathologically, these are lesions are seen in three structures: blood vessels undavu, thrombi, which is leading to specific infacts, which may again form abscess. So necrosis of the tissues are common, and lung parenchyma, hemorrhagic necrotic areas with the cavitations are seen. So staphylococcus also will cause the necrotic changes in the lung tissue, and also lesions are more complicated than the pneumococcus and other one. Plugging of the bronchus with pus will be there, and this is the slide which is showing the staphylococcal pneumonia, or the organisms will be presented like this. Next is the Haemophilus pneumonia. So it is a gram negative organism. Type A to R can cause pneumonia. So it usually occurs between ages of 3 months to 3 years, and it usually begins in the nasopharynx and spreads locally or through bloodstream. It can cause bronchopneumonia or lobar pneumonia, and it causes apple green sputum. Apple green color sputum will be presented. Klebsiella pneumonia. Klebsiella pneumonia, it is a gram-negative capsulated organism. The infection is more common in immunocompromised children. So that is about the Klebsiella pneumonia. And it causes alveolar destruction, copious mucinous or mucopurulent exudation, abscess formation, and pulmonary cavitation. Consolidation may be lobular, or the whole lung may be involved, and upper lobes are more involved than the lower lobes. So that is about the Klebsiella. Next is the Loeffler syndrome. That is a eosinophilic pneumonia. That is a non-specific, in non-specific agents we have seen the eosinophilic pneumonia, and it is known as Loeffler syndrome. It is due to an allergic reaction to a variety of agents. So larvae of many nematodes during their life cycle enter the portal circulation, liver, and pass through the hepatic vein and inferior vena cava into the heart and lungs. So that is a one of the method by which it occurs in the lungs. The larvae penetrate the capillaries, enter the alveoli, plug the bronchi with mucus and eosinophilic material due to allergic reaction. And some cases may be due to drug reaction to aspirin, penicillin, or sulfonamide. So that is about the Loeffler syndrome. So eosinophilic pneumonia, how it is occurring, and that is mainly because of the larvae of nematodes, or otherwise it can be because of aspirin, penicillin, or sulfonamide. Next is the hypostatic pneumonia. That is prolonged passive pulmonary congestion is seen, and it occurs in any marasmic state. Malnutrition states we can see the hypostatic pneumonia. Lying in one position for a prolonged period favors the pneumonia. So especially when bedridden people will be getting this particular pneumonia, and dependent congestion and edema will be the aspiration pneumonia. Chemical pneumonia is caused by aspiration of kerosene, furniture polish, and mechanical aspiration pneumonia can be because of inhalation of foreign body. Bacterial aspiration pneumonia after a bout of unconscious state or surgery, and it may cause immediate death due to aspiration. So that's about the aspiration pneumonia. Next is a viral pneumonia. So respiratory syncytial virus is the most important cause in infants under 2 years of age, and the bronchial tree or alveoli are involved, resulting in interstitial pneumonia. There is no clinical evidence of consolidation, because comparatively the complications and the fluid production and other complications are more common with the bacterial pneumonia than viral pneumonia. So we will continue with the diagnostic investigations and management in the next video. Thank you.